We get a ton of requests for specific types of rehabilitation programs using BFR at headquarters at Smart Tools. And so I decided to commit some time doing these monthly webinars with a focus on rehabilitation. So tonight's going to be tendinopathy, tendon injuries. I kind of wrote it not knowing who we were going to get. We had close to 300 registrants. So I wasn't sure who was going to join me tonight. So we have a lot of therapists, a lot of strength and conditioning specialists, some physicians, some other people. And then we also have non-medical. So I'm going to kind of just take it from the beginning and what I see in the clinic pretty much all day, every day, really. I treat a lot of tendons. And then later next week, I'm going to start a series for different conditions specifically. So tonight's going to be more of a broad overview on tendons and tendons themselves. Then next week, I'm going to start breaking them down. I'll share what days those are going to be. But Achilles, lateral and medial epicondylitis, rotator cuff, patellar tendon, gluteus medius, tendinopathy, ones that I see very commonly in the clinics. If you have any questions, just kind of put them in the chat. I will get to them because I do have time set at the end. I'm gonna get started. I'm gonna share my screen. All right, so BFR for tendinopathy, kind of evidence. I'm gonna show you some of the research that backs using BFR, and then I'll be giving you a bunch of anecdotal, just what I see in the clinic and how my outcomes over the last 5 or 6 years really crushed my outcomes from the previous 20 years of being in practice. A little embarrassing to admit I've been in practice for so long, but my name's Ed LaCara. I practice full-time in Dallas, Texas. My clinic is Body Lounge Park Cities. And then I guess you could call it as a side gig. I am the director of education for Smart Tools. I'm board certified in both sports medicine and rehabilitation. And I'm in my last year of a family nurse practitioner program. My clinic does primarily everything from functional medicine, primary care, peptides, hormones, hyperbaric chamber, heavy weightlifting, BFR, high intensity interval training. I have a DEXA scan machine. We have cold plunge. We have sauna. We have red light. We do a lot of wellness. Modality wise, I for my tendons especially, and I'll talk about it a little bit, I use a lot of sound wave or shock wave. OrthoGold 100 is what I use. But of course, a lot of rehabilitation and exercise as well, and especially with these acute injuries using BFR. And the real reason that we use BFR is we can start using BFR exercises early on in the rehab process, which I think significantly speeds up the rehab process. This is my better half, my wife, Copper. She and I both own our clinic. And I've also written a book, My Approach to Blood Flow Restriction Training. Published this back in 2021. And I wrote this for everybody. It's not really too clinically based. It has references and stuff, but it's really a pretty easy read. If you're on Instagram, this QR code gets you to my Instagram if you're interested in following me, which I'd appreciate. All right. First off, if we're talking about tendons, I think it's important to define it. Like, what is a tendon? And in short, a tendon connects a muscle to a bone. So if you look at these anatomy apps, or the anatomy app pictures, I took screenshots. You'll see the big red muscle, like here's your bicep where my pointer is. And at the ends, you're going to see white areas. These white areas are the tendon. So what I learned a long, long time ago is how to remember what a tendon does is muscle to bone equals tendon. Muscle to bone equals tendon. And then to compare that to a ligament, I was told bone lig. So you have muscle to bone as a tendon, and then bone lig means a ligament connects bone to bone. Muscle to bone, tendon. So what we'll talk about is why these are white compared to the muscle that is red, and why this contributes to how tendons are so difficult to recover from when they're injured. So from some basic anatomy, a healthy tendon is densely cross-linked with type 1 collagen. It's highly organized. Healthy tendons are white, like you saw in the previous picture, fibroelastic. They've got a little bit of give to them, but not much. They're full of, primarily full of tendinoblasts and tenocytes. So 90 to 95% of tendon cells are tendinoblasts and tenocytes. And from a rehabilitation perspective, it's important for me to know that because I want to try to do things that improve those tenocytes and those tendinoblasts, which happens to be a lot of times exercise and heavy loading exercise. And if we can't do heavy loading exercise, then BFR can mimic it. And then the remaining 5 to 10% of those structures are chondrocytes, synovial cells, and vascular cells. So very, very small amount of vascular cells, very small amount of endothelial, capillary, and smooth muscle cells. Primarily, these are tendinoblasts and tenocytes. From a metabolic characteristic, their oxygen consumption is very low compared to muscle tissue. And so why that's important is that there's a very limited oxygen supply. And so they have a low metabolic rate, which means that they slow heal after an injury. But even a slow heal from recovery from normal exercise, normal muscle we can repair, depending on how intense you worked out, we should be able to repair that tissue within about 48 hours. By that time, you should be pretty well recovered, be able to reproduce the force production that you were able to do in that original workout session. Tendons are slower. Tendons can take up to 96 hours. And so where I see a common problem is that patients will play, let's say, tennis or golf or pickleball day after day after day, and they don't give their body a break. And it's a compounding effect, and where you get these cumulative trauma injuries. So not having the days off in between really makes a difference, even on these lower intensity type workouts and exercise, because it becomes an overuse issue more times than not with a tendon compared to an acute trauma. And just a couple studies down there looking at the tendon fibroblast divide slowly, limited blood flow and low metabolic activity contribute to delayed healing and high risk of overuse injuries. And just a few studies in there just to kind of back up what I'm saying. When you hear tendinopathy versus tendinosis or tendinitis, we have to think differently, because commonly patients will come in and they'll say like, oh, I've got an Achilles tendinitis. Oh, really? Okay, well, when did that start? I'll ask, and they'll say, oh, it was about 6 months ago. Well, it's different. 6 months later, that injury is much, much different than it would be within the first couple of days. So like within the first week or two, I'll call it a tendinitis. That means that there's inflammation in there. And it's normally from overuse. And then if we look at tendinitis versus tendinopathy or tendinosis is going to be more your kind of chronic or subacute, like from weeks to months. It's been going on for a long time. So tendinitis is going to be acute from days to maybe up to 2 weeks. Tendinosis is going to be more chronic. That's going to be from a couple weeks to months to years. And then tendinopathy is the general term for any type of tendon disorder. So I tend to call things tendinopathies just so that there's not confusion and I'm not contributing to confusion in the marketplace. Commonly with a tendinitis, you're going to see inflammation and redness because it's an acute injury, whereas tendinosis doesn't really look like that, but it will get thick. And so you'll see a thickening, especially in the Achilles. You'll see this thickening effect, or you'll see this in patellar tendon, where that thickened tissue has been a result of long cumulative effects of either microtraumas or traumas themselves. From a pathology standpoint, that tendon, once it's been damaged, is mechanically less stable. And histological differences between normal and tendinosis tendon, they kind of look like this. You'll see this nice picture in A, which is this nice, smooth, very organized, I like to call it like a side cut of lasagna because of the layers. You can see these layers of the tissue, and then you see a much less organized, more inflamed tissue in the tendinosis, or the B picture. So basically this tissue changes, and it's, as the longer term that we have the inflammation goes down, but the tissue itself becomes more frayed. So you get these little micro tears in the tissue. And that's where I was saying it's really important to rebuild those tenocytes and do things that try to regrow those tenocytes. Common sites that we'll see these tendinopathies in the clinic: lateral and medial epicondylitis of the elbow, patellar tendon of the knee, Achilles tendon of the back of the calf, in the rotator cuff, and it could be any 4 muscles of the rotator cuff. I see it mostly in infraspinatus, sometimes in supraspinatus, but mostly infraspinatus from overhead work. And I see a lot of tennis players. So serving and that overhead action is really where I see that overuse. And then the backhand with the infraspinatus as well. From a classic presentation, you're going to have pain at the site, and it's typically load related. Pain usually will, if it's very mild, I'll see, if it's a mild inflammation, like it's just kind of like an overuse, I maybe did a little too much, they'll tend to be more stiff and painful after rest. So after, like, I've been sleeping, you get up, things are stiff. Kind of think of it almost like a plantar fasciitis, where it's painful on the first couple steps and then it warms up. And then the more damage there is, the more, if it's more of a tendinopathy, it will get worse over time. It won't warm up. That's usually a pretty good indication that there might be larger tears in the tissue. And it might require me to get an MRI to see exactly what's going on, because I typically can't see those on diagnostic ultrasound unless it's big. So early tendinopathy or tendinitis, really pain at the start of activity. It'll reappear after cooling down. Pain may worsen on repeated attempts. Patients can localize the pain clearly, meaning they can point directly to it. It's not broad. And its pain is often described as severe or sharp in the early stages, and then it's a dull ache, and it'll spread as it goes on. One thing I really wanted to point out, and what the literature is really pointing to, is the importance of really feeding our body and giving ourselves the proper nutrients in order for us to heal. If I have patients that are playing 4 or 5 days of tennis a week, I'm putting them on amino acids and I'm putting them on collagen and vitamin C, because we need that collagen turnover in order to keep the tissue healthy. I also have them make sure they're getting proper sleep, that they're staying well hydrated, that they're trying to avoid alcohol as much as possible. And really, I try to get them off of anti-inflammatories especially after the acute phase is over, because really it's no longer inflammatory. It's the inflammation's gone, and so now you're just tearing up your stomach and overusing your liver, depending on what you're taking. And so there's been some interesting studies, especially from Bayer at UC Davis, which is, I'm very proud, because that's my alma mater, a place that I wrestled and tore my ACL. What he's really discovered is that by preloading exercise with collagen and vitamin C, like 10 grams of collagen plus about 1,000 milligrams of vitamin C about a half an hour before exercise, or your rehab process or rehab exercises, or maybe before you go to PT, can really improve those tenocyte proliferation or synthesis, trying to grow more of those tenocytes. So I highly recommend, for people that are playing a lot of these sports, especially sports where we're having to hold a paddle. We weren't really designed to hold these things, and so they become stressors on the tissue, and making sure that we're feeding our body and hydrating our body and getting sleep and doing all the things that we need to. But my point of all this is current evidence is really pointing us towards, there's not one specific treatment for these things. Like there is very important to load them. Absolutely. I don't believe in just rest for any of my rehab processes, but having conversations with our patients and clients around proper nutrition and hydration and all these things is important too, because when you think about it, why do some people respond differently to the exact same modalities? Like I'll have somebody that does great with just a couple visits, and they're back on the court or, you know, back on the golf course. And then I have some patients that really, really struggle. And it really points to underlying comorbidities, diet, hydration, all these other things that we do have control of. So just kind of bringing that to the forefront, that it is very, very important to take care of those recovery items. And also metabolic factors play a role too. So if I have a patient that has diabetes or hyperlipidemia or is obese, their risk of severity is higher. And this was looked at by a group here in 2018. And so I'm just going to know that it's going to just take longer to recover from these conditions if I do have metabolic syndrome, and just kind of take that into account when I'm telling somebody, because everybody wants to know, like, how long is this thing going to take? And so I have to, you know, I have to just rely on experience, but also what's in front of me, and if there are other comorbidities, why it might take a little bit longer to get full recovery. But I did throw in a bunch of other studies in here that you can take a look at. So some of this metabolic turnover will slow if we aren't as metabolically healthy. And it's one of the reasons why, even if I have a patient that, let's say they have a tennis elbow or a golfer's elbow, lateral epicondylitis, medial epicondylitis, I make sure that they're doing some sort of cardiovascular exercise. You know, I just might have them walk if they're not currently doing anything, but I try to maintain that cardiovascular stress, because it's very important to get and help get the oxygenation to tissue. You know, some other studies that kind of back this statement up: type 2 diabetes, about 80% may develop musculoskeletal complications, increased tendon disorder risk. And then metabolic syndrome, which I'm sure most people here are familiar with. It's a combination of a lot of different items. High visceral adipose tissue, high blood pressure, high LDL cholesterol, a waist circumference in men greater than 40. If you have three of these or more of these factors, then metabolic syndrome is probably at play. And what that means is that you're not able to utilize the blood sugar in your system, and it creates an inflammatory process. And if we're constantly inflamed, it's really hard to recover and heal from injuries. So just very important to look at when we are treating folks and addressing their diet, exercise, etc. If we look at current management of tendon issues from a medical management standpoint, you know, we can use corticosteroids in a really, really acute. I don't like to penetrate the sheath, but kind of just either get it systemic, like a dexamethasone or Toradol. And then also peptides have now become also part of our medical management as well. BPC 157 and a TB 500 blend works very well. I usually do that over a course of about 8 weeks to help the healing process. And then, of course, they're doing that in combination with manual therapy and loading of tissue. You know, we all kind of look at Alfredson's studies. I know there's been some research that have kind of poo-pooed Alfredson's eccentric loading. I still use it a lot. I like loading tissue in a lengthened state because it makes sense to me that if the tissue is disorganized, then I'm going to lengthen it. It doesn't mean I'm not going to go to concentric at some point or a shortening of the tissue, but I do tend to like eccentric loading. It's I can do it with BFR, and it doesn't have to be very, very heavy load, and I can still get really good benefits. Modalities, I use a lot of shockwave with these because shockwave stimulates your own stem cells without having to use exogenous stem cells. It also brings blood flow to an area. And like we said before, there's not a lot of blood flow in these tendons, so we want to get blood flow there. There's also a neurological effect. It seems to taper down the pain response. A lot of people will use dry needling or even wet needling. Dry needling is using acupuncture needles to go into the tendon and into the muscle. And they'll use a little pistoning to try to cause bleeding, especially in a chronic condition where there has to be like a reset of the inflammatory process. So we can use needles to do that. We can do wet needling as well. I'll sometimes do that just with even saline, and you're basically going into the tissue and you're bombarding the tissue to create an inflammatory process. I know some providers, like with an Achilles, they'll go in with saline and they'll go try to get in between the tissue using ultrasound, and they'll kind of separate the tissues out so that they can glide and slide better with good results. Some providers will use platelet-rich plasma injections. I will say I tend not to, just because really that PRP is only as healthy as the donor. And so get better results using exosomes or stem cells because they're just healthier tissue. And, you know, if I'm 52 and I got a tendon issue and I need some exogenous help, outside help, then I'm not going to use my own PRP because, you know, I'm old. So I'm going to use something that's healthier and that it's more vibrant, like an exosome or a stem cell. Of course, I love using BFR with these, and the primary reason is we can really use light loads, but trick the body into thinking that it's using heavy loads. And we're using very low intensity exercise, something around 20% of one's 1 rep max. I kind of assuming everybody that's here is familiar with BFR, so I didn't go into a deep dive into like what BFR is. But if we have questions at the end, you can kind of ask me. But you're basically using a cuff to reduce blood flow into the limb, and then fully occluding blood flow out of the limb. And what this does is it creates it's a low oxygen environment, and you get cellular swelling and metabolite buildup. And you kind of trick the brain into releasing more growth hormone, which of course in the presence of vitamin C can be very helpful for healing. And then also you get increased testosterone production and some other things, all things that are very helpful for these healing tissues. So again, using the BFR, we use normal low load exercise. We can also use high load training after that BFR has been exhausted. Usually after about 6 weeks, I'll switch from BFR to high intensity training in those that I can. So yeah, so that's basically it. There's been quite a few studies using BFR for tendinopathy. Sentner in 2022 used BFR and low load resistance, improved strength and function of patellar tendon. This one took a little bit long, 14 weeks. 14 weeks, you know, on MRI. I mean, that's what it might take. I mean, I would think that, I mean, I see results. If there's not a major tear in the tissue, I'm going to see results very quickly, like 2 to 3 weeks. But to actually see change on an MRI is going to take much longer. So they saw these changes in 14 weeks. Burton and McCormack in 2022 helped, you know, looked at pain, function, strength, and tendon morphology. And 2024, Kara et al. With patients with rotator cuff tendinopathy. So, you know, there are plenty of research out there demonstrating improvements using BFR because of being able to use the lighter loads. So you can probably start BFR much earlier than you would normally do heavy loaded eccentrics or heavy loaded concentrics. Again, I just want to remind everybody about the safety and screening. Very important that we pick and choose our patients safely. So you want to, you know, make sure that you're not causing more damage to the tissue by overloading the tissue. You want to be careful of anybody that has some sort of clotting condition. Careful with people that have uncontrolled high blood pressure. All these things have been looked at, and if patients or clients or yourself are cleared for high intensity exercise, then typically you're cleared for BFR. But if you have any question, then reach out. You can ask the questions in our school group, where there's a few of us instructors and myself are floating around, and we can kind of help guide. Who should absolutely not be using BFR without medical clearance? Somebody that has an active DVT or severe cardiovascular disease, uncontrolled hypertension, any type of heart failure or pregnancy. Make sure to use safe cuffs, monitor discomfort, and educate patients on the pressure sensations. So let me give you some examples of using BFR with some of these common conditions. So like an Achilles tendinopathy, I mean, you can use, I'll use them for isometrics, long holds, like a long hold calf raise, 1 minute hold with the BFR cuffs on, makes it feel like it's about 10 minutes. And then doing like, 1 minute hold with a 30-second rest, and 1 minute hold, 30-second rest, 1 minute hold. You can do wall sits for a patellar tendinopathy with a slant board. It's one of my favorites. So the knee is over the toes. Depending on what is contributing to the soleus or to the Achilles tendinopathy, you can either do more isolated soleus exercises or more isolated gastrocnemius exercises, or both. For anterior knee pain, I love the Spanish lunge or Spanish squat, basically that terminal extension, that far right corner with the gentleman really forcing the knee into extension. I get really nice results with this. This is basically a reciprocal inhibition, which I'm going to talk about in a little bit. But it's kind of my go-to right now with anterior knee pain. And I think I'm seeing it a lot on social media as well. For the shoulder, I still kind of go to my go-tos, banded external rotation or internal rotation. I tend to do them at 90-90 positions, meaning the arm is elevated. But you can also do them the standard, with it on the side with a towel rolled up. You can do long holds like the guy's doing on the bottom, especially for like a supraspinatus in a scaption position. The only difference, I might have it with his thumb down, so it's like an empty can position. But the isometrics with BFR are really, really nice. Low stress to the tissue, but high metabolic stress. I basically break my rehab programs for not just tendon injuries, but most injuries. Take out the spine. My spine doesn't kind of fall into this, but for my extremities, I basically organize them into 7 progressive categories, which I'm going to kind of share right now. And it's all about trying to increase load over time. So, you're going to load it lightly in the beginning so you don't make it mad. And then you're going to continue to load it up to the point of return to play or even afterwards. So the first thing I kind of think about is working around the tissue. So for example, if I have an Achilles tendinopathy, I won't work the exact tissue itself in the beginning, especially in the acute phase, first few days. Instead, I'll work the foot, which is distal. So that might be something like a short foot exercise or a towel scrunching or something like that. And then I would also do something a little more proximal, and I might do something in the Achilles if it's non-painful, or the soleus, depending on which tissue is contributing more to the Achilles tendinopathy. If that's too painful or painful at all, really, then I'll move up even to the hamstring. And so just kind of working both up and downstream, as I like to say, from the injury itself in the early phases, I think is really important. And then, of course, keeping their cardiovascular fitness up. And then I'll go into antagonist tissue, meaning like what's the opposite muscle group. So I will tend to do the opposite group in the early phase, especially for the first like 5 days of the injury. So for example, like if I have an Achilles tendinopathy come in, instead of doing any type of focused exercise on the Achilles in the early phase, I'm going to have them do antagonist, meaning I'm going to work the opposite side of the body. So in this case, heel walks for Achilles tendinopathy would mean turning on or activating the tibialis anterior. And I would do like maybe 2 minutes, 3 times a day. So they're really trying to turn on the opposite side. You could argue with me that actually stretches the Achilles tendon, maybe, but for the most part, you're getting a neurological relaxation of the tissue, which is what I'm looking for to help reduce pain. After about 3 days, I'll start 3 to 5 days, depending on how inflamed the tissue is. I'll go to some light stretching. So you might do like a calf stretch for this Achilles tendinopathy example with a straight knee or with a bent knee if it's more of the soleus. And then I'll go into some isometric loading. These are where I'll start with BFR. You can do isometric loading with BFR, keeping pain below a 2 out of 10. So that would be something like a calf raise and hold. Isometrics with BFR are typically done with in 1 minute on, 15 to 30 seconds interset rest, but you keep the cuffs inflated. So we keep the cuffs inflated throughout the whole exercise. And then doing like 3 rounds of that or so is probably enough. And then deflate the cuffs between exercises for a minute, and then reinflate and go to a second exercise. Eccentric loading would be next. So depending on if it's an insertional Achilles tendinopathy or it's a non-insertional, will depend. If I drop heels below toes, like on a stair step, you got to kind of be careful with those insertionals. So we tend to just do it to flat, to just a straight ground, and not use steps for those. Decline squats can also be really helpful with those. And then we go into concentric loading. That's where I'm trying to load the tissue. If I'm using BFR, then I'm using like 20 to 30% of somebody's 1 rep max. And we're going to do the typical 30, 15, 15, 15 protocol. I know a recent study came out demonstrating that you don't have to do the 30, 15, 15, 15. Honestly, we've known that for a long, long time. I didn't need research to demonstrate that for me, but I do still like using that framework. And the reason is it forces us to use lighter loads than we typically would. If they can do 30 repetitions, that means the load is light. That means that load is like 20%. And I really reduce my risk of injuring the tissue or re-injuring the tissue or aggravating the tissue. So keeping those loads light, the loads don't have to be heavy when we're using BFR. That's the whole reason that we use BFR. And then once we're ready, then we start getting into some plyometrics. I love the jump rope for my racket athletes. 5-dot drills, single leg, over the lines, things like that. I think are really important, that are underutilized, and why we actually get a lot of these patellar tendinopathies and Achilles tendinopathies and glute medius tendinopathies with individuals that are playing pickleball and tennis and stuff, because a lot of times they just run on the court and play. They don't warm up, they don't do anything. And so kind of just teaching them to put a jump rope in their bag and just do 5 minutes of jump rope, before they play is, I think, goes a long way. Making sure they're hydrated, things like that I think are very helpful. I kind of gave you that example of the Achilles tendinopathy. So utilizing that BFR once we start getting past the stretching phase. I don't do any stretching with BFR. Not that you couldn't, but I don't really see too much of a benefit with it. And you're looking at 2 to 3 sessions per week of these resistance training sessions, like 3 to 5 exercises in those training sessions. Here again is an example of the Achilles tendinopathy that I might use. I won't read through it because I basically did it all. And I do want to emphasize that just because these are my exercises doesn't mean they have to be your exercises. This is just kind of a framework. The beautiful thing about BFR is that you still use the same exercises you do when you do normal loading. You just don't have to use as much weight. So if you have your own Achilles tendinopathy go-to exercise protocol, keep using it. Just add BFR to it. I did throw in a couple of things. Number one is I like to protect tissue, especially the tendons. For hard to protect an Achilles, but the way that I typically do is I'll use a lift in their heel to try to take stress off. I'll have them wear shoes with a high heel to toe drop. I'll have them use women, I'll have them use wedges, like wedge sandals. So that way their heel is elevated for a couple days. If I need to put them into an over-the-counter insert, I will. Men, I'll typically put heel lifts in. And that helps to reduce the stress on the Achilles. And then, and of course, then I'll be treating them with shockwave probably twice a week for 2 weeks, and then probably once a week for 2 weeks. And usually by the 6th visit, I'm pretty out of the woods. And then we just continue with progressive exercises through about week 6 to 8, depending on the severity. Again, the BFR protocol is 3 to 5 exercises per session, 2 to 3 times per week. repetitions are that 30, 15, 15, 15 with 30-second interset rest. And then you only deflate the cuffs after each exercise. You're using 20% of 1 rep max, and or the ability to be able to do 30 repetitions with the limb. And then limb occlusion pressure should be about 60% in the lower extremity, 40 to 50% in the upper extremity. I'm going to open it up to questions, but some key takeaways. BFR enables effective tendon loading at lower intensities. It complements but doesn't replace eccentric and other concentric protocols. Growing evidence supports BFR in managing chronic tendinopathy, and then safety screening and proper application are critical. What's coming next? Next week, I will be doing Achilles tendon protocols, and then also the gluteal tendinopathy protocol, or at least my protocol. And then patellar tendinopathy the following week, rotator cuff tendinopathy the following week, and elbow and shoulder rehab on October 30th. All right. This PowerPoint will be available, so you can have a copy of this. I'll put it in the portal where you guys registered for the webinar itself, and some references. All right. Any questions that I can answer? I'll start at the bottom. How long should a BFR session be, and how many exercises? I think I answered that. 3 to 5 is a typical BFR session. BFR 30, 30, 15, 80% LOP for lower extremity. So it can be up to 80% LOP, but it doesn't have to be. And I tend to use 60% for most of my lower extremity. Most of my lower extremities are going to be 60%. Do I have a preferred shoe for Achilles tendinopathy? Currently using a Hoka Bondi, but unsure if there's a better I should try. Mike, I would look at the heel to toe drop and get something that's at least 12 millimeters. I like the New Balance. New Balance also just came out with a more supportive, I think it's called the M33, I believe. And I'll use it a lot for patients with a lateral or peroneal tendinopathy. It prevents eversion. So I like those New Balances. Monica, what if a person doesn't know what their 1 rep max is? Yeah, this happens a lot, and it's really just a guess. You could use the non-involved leg to see what their 1 rep max is, or you could estimate their 1 rep max with a 5 or a 10 rep max. If you go to my YouTube channel, just Ed LaCara, you can find estimating your 1 rep max. There's basically a formula if you know what somebody's 10 rep max is. But ultimately, it doesn't matter. Like, you want to just get the tissue tired. And if it takes 30 reps, fine. If it takes 40 reps, fine. I mean, I don't want it to take so long. It takes, 10 hours. But you can kind of guesstimate and see. And if they can't quite do 30, then lighten the load. And if they can do 40, make it a little heavier, and you just have to kind of play with it. What is the criteria for advancing from one phase to the next, and over how many weeks? It all depends. I mean, I'm very strict with my patients about the first 5 days not stretching tissue. And then after that, it's just basically what they can tolerate. Like, some people will, the healthier, younger, I mean, I swear my high school kids just fly through rehab. But of course, they have growth hormone and testosterone running through their body and insulin growth factor. And then my older patients have a tougher time, and I just really think it is individual. I would say that, if you try the next phase and it aggravates them, or there's pain above a 2 or 3 out of 10 while they're doing the exercise or the loading, then you got to back down to the next one. And I would be lying if I said I don't push people a little bit too fast sometimes, and I've got to back them down into the previous stage until they're ready for the next stage. Mike asked, stem cells, are there concerns with the stem cells differentiating into other tissue? Example, injected into tendon, turn into bone instead. Yeah, not really. I don't like to penetrate the tendinous sheath unless you're trying to create more inflammation, and I typically won't do that with something expensive like a stem cell. I'm going to do that more with just straight saline, or a dry needle, and just pepper that thing with a bunch of needles to try to create some bleeding in there. But no, I'm not concerned about it differentiating into other tissue. In hyperlipidemia, what kind of total cholesterol and or LDL is a threshold, and where to start? Where it start? That's a good question. I don't really know, exact number. I don't think the exact numbers have been looked at. I'm not a huge cholesterol guy. Like when even if somebody comes in and their cholesterol is a little bit elevated, I'm not too crazy concerned. It's more about inflammation in the body and blood sugars and metabolic syndrome itself. It will help lead us to that diagnosis of metabolic syndrome. But to me, it's more of an inflammatory process in the vessels that are the problem, where your LDL is having to be manufactured to create basically a paste in the cells, and then that becomes the plaque and is hardened and becomes an issue. Not really when it's hardened, it's much less issue, but I digress. So I don't have an exact number, and I don't think that number has been identified. I think that just the basic take home from all those slides is that people are going to be slower healing if they're not as healthy and they're not as metabolically active. Can BFR be beneficial in chronic tendinopathies? Yeah, for sure. I mean, these chronic tendinopathies I find have not been loaded. Most of the people that come into my clinic that have had these things for long periods of time, there's either a biomechanical dysfunction that hasn't been addressed, severe hyperpronation, severe hypersupination, a lack of ankle dorsiflexion. Like I have one patient who had ankle surgery. He was a Formula One race car driver, got in a crash. He's got a ton of metal in his ankle and he has like zero ankle mobility. And it's like, that's a biomechanical issue. He came to me with this Achilles issue. And it's like, well, what are we going to do about it? The best I can do biomechanically is elevate his heel, keep him in a, kind of this high heel to toe ratio to compensate for that lack of dorsiflexion. And load the shit out of it, and just keep loading it. I did use shockwave with it, which worked very, very well. I'm probably 16 or 20 weeks in of continually loading that thing 2 or 3 times per week. But he's made, great progress compared to, he's playing tennis and pickleball like 4 or 5 days a week now. Whereas before he wasn't doing anything. So yes, BFR absolutely can be beneficial. Now you may have to, with those chronic tendinopathies, create an inflammatory process to kind of reset the system. So meaning using like a dry needling or a shock wave or something that's going to create blood flow to the area, and then make sure they're not using any anti-inflammatory during that time, because you want the body's natural healing process to kick in. I've heard about some impact of metformin on helping to resolve tendinopathies. Any experience? Well, I think that I haven't seen those studies, Mike, but it would basically back up what I'm saying, is that sugar is the inflammatory process that we are having to deal with and creates this havoc. That's why type 2 diabetes and other things leads to more of these tendinopathies and musculoskeletal issues. And if we're using a metformin or we're using a GLP, drug to keep blood sugars lower, I mean, we see crazy results on our patients with GLPs because they're keeping blood sugar lower, not necessarily in a tendon issue, but in overall just chronic inflammation and brain fog, and their numbers get way, way better on their labs, and just overall healthier individuals. So I believe that metformin could have a role, but yeah, I'll just stop there. I mean, I think getting them off of the sugar and getting them more metabolically active, so the sugar is not sitting in the system, is really important. And it's basically turned into my primary goal in the clinic. Yes, sir, my pleasure. Any concern on using BFR with patients who have EDS? No, I mean, they're obviously going to be hyperflexible, and I have more of a concern with manipulation with those people. than I do with exercising those people. I haven't had any problem. Best exercises for a rotator cuff. Harry asks this. Like I said before, I don't really have best exercises. I have the ones that I like. But for a rotator cuff, when you're using BFR, it's because the cuffs, if I'm putting this cuff on, this cuff is on and it's distal to my rotator, right? So if I need to tax the that rotator cuff, then I need to stress my distal muscles first. So if I'm gonna do specific BFR strengthening for the shoulder, I'm probably going to do at least one bicep exercise and one tricep exercise first, get that tissue tired, and then go to the shoulder. Anything distal to the cuff, meaning further down towards the hand, when I have the cuff on, is going to get the best result. So if I do my bicep and I do my lateral medial epicondyle or lateral medial extensors or flexors, they get the best result from the cuff because the cuff is way up high. If I'm trying to get my glute or I'm trying to get my core, I'm going to have to fatigue the tissue distal first, in my opinion. So getting the shoulder, you're going to do a bicep exercise, you're going to do a tricep exercise, and then you're going to go into 2, maybe 3 exercises specifically for the shoulder. I'm a big proponent of getting serratus anterior active as hell when I have any type of shoulder problem, because that allows me to work tissue around, and that's a stabilizer. So like a push-up with a plus is going to be one. I'm probably going to do some rows with them without them allowing the scapula to rotate. So I'm working on stability. I love isometrics with like a kettlebell overhead laying on their back. So they got the cuff on and they're holding a heavy kettlebell in front and they're really trying to stabilize through their scapula. I tend to use more scapular stabilization than anything with the shoulder. And Brittany asked any concerns on using BFR with patients who have EDS, and I don't have any concerns with that at all. A vascular EDS, yeah. Any other questions for me tonight? I'm sorry I went longer. I went almost a full hour. I think I got all the questions. All right, well, thank you so much. I really hope to see you all next month, where we'll be talking about pre and post-surgical treatment using BFR, primarily with using the ACL as the example. Follow me on Instagram, and I will see y'all soon. Bye for now.